30 ml per kg. Ask most doctors what sepsis 2026 did to this number, and they will say that it's gone, but it isn't. The guideline clearly mentions 30 ml per kg in the first 3 hours as before. Same strength, same certainty. However, the key change occurs after this initial bolus of resuscitation. That means reassessment and knowing when to take the fluid which has been given, to take it back and to evacuate. The rule survived, the dogma around it didn't. Let's get deeper into the fluid resuscitation guidelines in Sepsis 2026 recommendations. 5 big changes in Sepsis 2026 guidelines. I've already covered the summary video as a standalone with all 5 changes summarized in one snapshot. Then we have this 5-part series. The video 1, episode 1 was about screening protocols, Q so far versus news 2. This particular video is episode 2 about fluids, fluid resuscitation and removal, etc. Then the following 3 episodes will be, episode 3 will be on antibiotic usage, episode 4 will be about vasopressors and the target map according to different age populations. And finally, episode 5 will cover the de-escalation of antimicrobials, which is now a strong recommendation. And all this 6-part full video series is linked in the description if you want to review each and every episode. So basically, part 1 of this video will cover the fluid resuscitation phases and the clinical evidence behind those. Number 1, a 4-phased approach fluid resuscitation framework, which includes resuscitation, reassessment, post-resuscitation, and fluid removal. Second point is that why balanced crystalloids are now preferred over normal saline based on SMART and SALT ED trials. Number 3, albumin and resuscitation. Crystalloids first, and in what select type of cases an albumin still has a role, if any. And finally, the active fluid removal, really brand new recommendations, which was not in Surviving Sepsis Campaign in 2021. While in the second part of this video, I will be going through some clinical application of these guidelines, because it's no use if you just know the theory, but you do not know how to apply them in practice, and that's really useful. And also some clinical examples like MRCP and USMLE exams. So I will be covering the dynamic fluid response and the tools to guide reassessment beyond the 30 ml per kilogram rule. Number 2, liberal versus restrictive fluid resuscitation. So where are we based on the classic and CLOVERS trial and evidence? What do they tell us? And finally, practical bedside framework. Which phase is your patient right now and how to assess that in practical and simple terms? And they will be covering MRCP pearls like hyperchloraemic acidosis, the make 30 evidence, fluid overload, and exam targets that you need to know about. So before we go further, this 30 ml per kilogram rule, let's talk about it. Is it really dead? It was an old rule used for decades. Are we still using it? And if so, what has changed in terms of the guideline and evidence, and what should we be doing dynamically for our patient resuscitation? Basically, prior to Sepsis 2026 guidelines, the key rule of thumb was 30 ml per kg of IV crystalloid to be given to patients with severe sepsis, which was a definition at that time, and septic shock in the first 3 hours and then reassess. So what were the 3 problems? Number 1, it was a standalone single formula of one size fits all, irrespective of patients' cardiac status, renal status, other comorbidities, and that led to both over resuscitation and under resuscitation in different subsets of patients. So that's the problem. There was no homeostasis or balance like our AG Dove. Then the second thing was there was no clear policy of, okay, what should the clinician do after the 30 ml per kg resuscitation in the 3 hours? So the guidelines were not clear. It was vague. It was all individualized and hit and trial method. And thirdly, what if there was fluid overload? So what would you do to de-resuscitate or remove that excess fluid? Because the clinical evidence clearly suggests that volume overload can lead to acute kidney injury and higher mortality. Now, please remember that the 30 ml per kilogram resuscitation fluid in the first 3 hours is still retained in the 2026 guideline. It has not been removed at all. But it is the starting point of a 4-phase framework, and that's why it's not a standalone protocol. So this is a misconception. The 30 ml per kg rule still applies. In terms of this presentation, what we have done is we have adopted this into a 4-phase teaching scaffold, which is aligned to the ROSE concept. We'll come to that. This includes the initial resuscitation, the reassessment, post-resuscitation strategy, and finally the fluid removal. So please remember that it has not been framed or named as such in the Surviving Sepsis Campaign 2026, but I have adopted the ROSE model and used this as a teaching learning point. So you can use your own individual institutional policy, departmental policy for the best strategy, but this is more of a guidance and educational principle, which I'm sure you would appreciate. So basically, the 4-step resuscitation model that I have used here in this video is based on the ROSE framework, which in itself is in the study by Madelbrain published in 2018. And the 4 abbreviations are ROSE, R-O-S-E, resuscitation, optimization, stabilization, and evacuation. And I've just modified them slightly by resuscitation, and instead of optimization, we have reassessment. Stabilization is the post-resuscitation phase, and finally the evacuation is the active fluid removal phase. Do not worry about the fine print details. We will discuss in the subsequent slides, but basically the resuscitation involves when do I start fluids. The next question is when do I stop fluids. So that is the optimization phase of the reassessment phase. So once you've resuscitated, you reassess. The third pillar is the stabilization or the post-resuscitation. At that stage, you have to decide when do I start removal. And then that means the body or kidneys will, if they're going to fluid overload, then the kidneys will automatically start to neutralize the balance and achieve euvolemia rather than hypervolemia. And finally, the evacuation or the active removal phase means once that is happening, you are using diuretics and other modes of ultrafiltration, etc. Then you have to also think about when do you stop the fluid removal. So that is a key thing. So this is the 4-step model. Please remember that the Surviving Sepsis Campaign 2026 and the sepsis guidelines in themselves do not name this framework as such, and it's not like this model is not recommended in there or not narrated as such. It's quoted as an evidence. So this educational purpose of this framework is to make sure that you understand that this is a learning strategy that you can apply in your daily practice, but again, individualized according to your clinical guidelines and your local institutional policy. So I discussed about the ROSE framework, resuscitation, optimization, stabilization, and evacuation in the previous slide. So based on that, I just modified it slightly and used my own mnemonic. So my mnemonic is the R4 framework, which is R for Raza, which is me. So Raza's R4 framework. Resuscitation, reassessment, post-resuscitation, and removal, which is the fluid removal. I leave it up to you, whichever of the two you like, whether you like the ROSE framework, which was as per the original study, or the R4, Raza's R4 framework. Please feel free to choose. Okay, so coming to this 4-phase fluid model, let's look at the phase 1, which is the resuscitation. So let's look at the phase 1 in a little bit more detail. In terms of the 2026 guidelines, the 30 ml per kg rule is still retained for the first 3 hours. However, it's first step of the 4-phase model. And the frequent reassessment of the patient after the initial administration is now explicitly mandated, which is a key change. The goal is to correct the hemodynamic instability and restore the perfusion pressure so that the vital organs, the tissues have proper oxygenation and fluid and delivery of the fluid. And maintaining mean arterial pressure is one of the key things, and making sure that lactate is less than 2. Now, this resuscitation period is not a rigid endpoint, unlike previously, and that is the new change, which means the dynamic reassessment is crucial. In terms of the balanced crystalloid, to be preferred over normal saline, 0.9% saline, the evidence has been upgraded. And this is because the plasma light and Hartmann solution, which are balanced crystalloids, have lower chloride content of around, you can think of it like at around 100 millimoles per liter, 98 to 111 is the range, unlike the normal saline, which has 154 millimoles per liter of chloride, so almost 50%, 50 to 60% extra chloride. And it's the supraphysiological concentration of chloride which leads to hyperchloremic metabolic acidosis. Plus, the plasma light and Hartmann's have a natural buffer like lactate, acetate, and gluconate, which the body can convert into bicarbonate. So that's much better in acidosis environment. So that's why the SSC guideline in 2026 retained the conditional recommendation of using the crystalloids, but the evidence has been upgraded based on the SMART and SALT ED trials. So what was the clinical evidence behind this? The systematic review that the SSC 2026 relied on used balanced crystalloids as evidence, and the clinical evidence suggested that the use of balanced crystalloids actually reduced the need for new renal replacement therapy. And the odds ratio was pretty strong, 0.86, and with a confidence interval, 95% confidence interval spanning to 0.74 to 0.99. So just on one side of 1. And this was with high certainty. Now, the important aspect is the mortality benefit. And in terms of mortality, the odds ratio was 0.94. However, the 95% confidence interval was not significant because it was spanning both sides of 1. It was 0.85 to 1.04. That's why the certainty for this particular evidence mortality was moderate. And you can summarize that the kidney signal was stronger than the survival or mortality signal. And the statement 44 in the SSC 2026 guidelines, they keep a conditional suggestion while they maintain, or the certainty for the evidence has been raised from low to moderate based on this particular evidence. In terms of MRCP and USMLE exams, so remember your MAKE 30, which is major adverse kidney events at 30 days. And this is the composite endpoint used in both SMART and SALT ED trials. And it includes death, new renal replacement therapy, and persistent creatinine elevation of 200% or more above the baseline at 30 days. And this particular endpoint, the MAKE 30, is increasingly tested in critical care environments, nephrology modules, and MRCP Part 2 and MRCP PACES exam stations and scenarios. So it's really important for you to pay attention to this particular evidence. So looking at the gold standard, AU, let's look at these both trials in a little bit more detail. So SMART and SALT ED trials are the two landmark 2018 trials comparing balanced crystalloids with normal saline. The SMART trial included nearly 16,000 patients who were critically ill adults. The primary outcome was the MAKE 30, which is a composite of death, renal replacement therapy, or persistent renal dysfunction at 30 days. And the MAKE 30 in SMART trial occurred in 14.3% of the studied population with balanced crystalloids versus 15.4% with normal saline. This gives an absolute risk reduction of 1.1% with a number needed to treat of 94. Now, this represents a modest individual benefit, but potentially meaningful impact across large critically ill populations. The greater treatment signal was observed in patients with sepsis, and although this came from subgroup and secondary analyses rather than the dedicated sepsis trial itself. As for the SALT ED trial, it included over 13,000 emergency department patients. The primary outcome in the SALT ED trial were hospital-free days, and that particular outcome showed no difference between the two populations. However, the secondary MAKE 30 outcome was lowered with balanced crystalloids versus normal saline, and that was 4.7% in balanced crystalloids versus 5.6% in normal saline. But there was no significant reduction in stage 2 or higher acute kidney injury alone. So that's why, if you combine both together, the SMART trial showed improvement in its primary outcome, which was the MAKE 30 outcome, whereas the SALT ED had a neutral primary outcome, which was different, the ICU, the hospital-free days. But the secondary analysis of SALT ED was favorable towards renal composite endpoint. Based on these two, the SSC 2026 retained a conditional preference for balanced crystalloids, with evidence certainty upgraded from low to moderate on the basis of this wider evidence. Now, an exception to this rule is or are patients with traumatic brain injuries, where normal saline is still preferred as a fluid. Now let's look at the phase 2, which is reassessment, or the optimization phase in the ROSE framework. The phase 2, which is the reassessment or the optimization phase of the ROSE model, it basically covers the dynamic fluid responsiveness. What does it mean? The core shift from the previous fixed fluid protocol to the dynamic assessment is the hallmark of SSC 2026. And basically, it emphasizes the need for the frequent and ongoing dynamic reassessment during and after the initial fluid resuscitation, which remains unchanged at 30 ml per kilogram boluses in the first 3 hours. Now, what is the aim? The aim here is to avoid both over-resuscitation, leading to fluid accumulation and fluid retention in the body, and subsequent respiratory and organ deterioration, including AKI, and under-resuscitation, which leads to persistent hypoperfusion and lactic acidosis. What does a fluid responsiveness mean? In patients who are in septic shock, fluid responsiveness will mean increase in objective evidence of cardiac output by 10 to 15% through any of the measures which we will discuss in the next slide, including passive leg raising or a fluid challenge. Now, many hemodynamically unstable patients are not responsive to fluids, and again, if you give further fluids, that can further worsen the outcomes and may lead to fluid overload and fluid burden rather than any hemodynamic benefit. So that's why dynamic assessment of fluid responsiveness is really, really important. Now, the static markers of fluid status like CVP monitoring, central venous pressure monitoring, or the pulmonary capillary wedge pressure, which used to be relied on in the past, has now been replaced with dynamic tests which are needed. And because these static markers are unreliable predictors of fluid status. So let's look at the reassessment triggers. In 2026 guidelines, the main ethos is the dynamic reassessment of a patient's volume status. For example, if there is 30 ml per kg resuscitation fluid in septic shock patients and critically ill patients with septic shock, 70 kilogram gentlemen will require roughly 2 liters, 2.1, 2100 ml in 3 hours. You don't give all 2 liters, 2.1 liter as a bolus over 3 hours and then just, forget about it as a standalone procedure. No, you have to reassess after every 500 ml bolus. And you need to look at the organ perfusion. The 3 main criteria that I always ask my juniors to think about is the target mean arterial pressure of at least 65 and above. Again, in elderly, above 60 is also acceptable depending upon comorbidities and certain criteria. But generally, 65 and above millimeters of MAP, mean arterial pressure. Serum lactate, ideally you should be aiming for a lactate of less than 2. However, a trend is more important than an absolute number. If somebody had a very high lactate of, let's say 5 or 6, and after an hour of resuscitation with fluid and you have done a VBG and it is already coming down to, let's say 4, that's a good marker. This means they are fluid responsive. The third is urine output, which again, you cannot have one size fits all. It's roughly 0.1 to 1 ml per kilogram per hour. As a ballpark rule of thumb, half ml per kg per hour is the minimum standard. For example, in a same 70-year-old patient, you would be expecting roughly 35 ml per hour. So these are the 3 key targets which are very easy to measure at bedside, do not require a lot of invasive monitoring, etc. And then during the same phase, you need to look at the signs of volume overload. And what are the key parameters in terms of observations? You can look at the respiratory rate. Are they becoming tachypneic or not? Are they requiring higher oxygenation? So increased FiO2. That is a key thing. Let's say initially they were on 1 to 2 liter nasal. Now they are requiring 4 to 5, or they're requiring face mask to maintain the same oxygen saturations. Clinically, do they have raised GVP? Do they have features of pulmonary edema like bivasopressors or mid-zone coarse crepitations on chest auscultation? So these are the markers of volume overload. Okay, so we have done the assessment for fluid responsiveness, then we looked at the reassessment triggers, the 3 targets, MAP, serum lactate, and urine output. Now, let's look at the goals of reassessment. So what do we want to achieve in our patient when we have done the reassessment? Basically, we want them to be euvolemic, not underfilled, not hypovolemic, and we also do not want them to be hypervolemic. So that's the key parameter. When would you consider the end point of fluid resuscitation in such patients. You remember, as we said, you don't have to wait for the full 30 ml per kg fluid resuscitation for 3 hours. It's a dynamic process. One of the things is if the patient is still fluid responsive, i.e., fulfilling all those criteria and the MAP is not achieved and they're responding to the fluid boluses and then the MAP is achieved or going higher and higher and the lactate is falling and the urine output is picking up. So that's number one. Number two, whether they have reached the hemodynamic stability. So MAP is maintained, lactate is okay. Regarding urine output, I'll give you one caveat because when I was working in nephrology back in Leicester General Hospital in my run through in my specialty training as a registrar in nephrology, we learned one very good point, which is that the renal urine output in acute kidney injury due to sepsis, septic shock, or any reason would lag behind the improvement in the hemodynamic stability and the lactate monitoring, because kidneys need to have a sustained perfusion for a good amount of time. So to be honest, in early resuscitation, the urine output may not be a very good marker to guide you with the fluid resuscitation initially, at least. But maybe let's say in 6 hours down the line and 12 hours, it becomes better and better in predicting. So if the lactate is maintained or normalized, MAP is maintained, patient clinically looks well, peripheral capillary fill, perfusion, cerebral perfusion, patient is alert or at least improving, I think those would guide us more rather than just pure urine output as one of the 3 hard criteria. Irrespective, once the hemodynamic stability has achieved, then you can transition to phase 3. And remember, the third R was post-resuscitation, or the S in the ROSE category, the ROSE framework, which was the stabilization. So resuscitation, optimization, stabilization. So either stabilization or post-resuscitation, whichever mnemonic, whichever framework you want to use. Both are the same thing. If you feel that the patient has got signs of volume overload, like we discussed, rising JVP, increased oxygen requirements, bilateral lung crepitations and crackles, then you can just go to the phase 4 directly rather than continuing with fluid resuscitation, and then you have to evacuate using diuretics and other modes and modalities. So let's look at some of the objective tools for the fluid responsiveness. We've discussed about the fluid resuscitation. So in terms of the assessment methods, I know it's a busy slide. So if you just break it down into 2 separate sets, it will become easier. So the 4 main dynamic methods of assessing the fluid responsiveness in patients after resuscitation with fluids are the pulse pressure variation or PPV, stroke volume variation SVV, passive leg raise which is PLR, and fluid challenge plus echocardiography. Now the PPV and SVV, the pulse pressure and stroke volume variation, are basically for ventilated patients with normal sinus rhythm. They're not good for arrhythmias and also the non-ventilated patients. So that's one arm. The PLR and the fluid challenge and echo, they are good for even people with arrhythmias like atrial fibrillation, but predominantly they are for non-ventilated patients. So that's one distinction. The pulse pressure variation measures the variation of the pulse during the ventilatory cycles, and variation tells them about the left ventricular preload and the responsiveness, etc. For that, once you give the fluids and the pulse pressure variation is more than 13% based on the fluid response, then it's a positive signal for fluid resuscitation and fluid responsiveness. The same mechanism goes for the stroke volume variation, but instead of the pulse variation, you're measuring the direct stroke volume cardiac contractility. So that's important part. Again, it needs echocardiography, and both require arterial line insertion because you need arterial waveform. In terms of the passive leg raising and the fluid challenge, both of them will require a real-time echocardiography. So you need someone with privileges and expertise of doing bedside POCUS, point of care ultrasound. Mechanism for passive leg raising, you just make the patient if they are in recumbent position, make them supine, raise the legs by 45 degrees. That will increase the venous return, which eventually should lead to, so higher venous return will lead to higher stroke volume, Frank-Starling law. So if there is immediate objective evidence of increase in left ventricular outflow tract velocity time index, the VTI, velocity time integral, that means the patient is fluid responsive. So VTI is the velocity time integral for the left ventricular outflow tract. But again, real-time measurement is important. Measure the LVOT-VTI real time. If there is a more than 10% increase, that means the patient is fluid responsive. Almost similar mechanism is the fluid challenge and echo. So rather than passive leg raising, we give a fluid challenge of 100 ml, measure the LVOT-VTI. If it's more than 10% increase, that's predictive of response. So both require real-time echocardiography. The stroke volume variation, I forgot to mention, the threshold is 10 to 15% increase. So PPV more than 13%, 13 or above. Stroke volume variation more than 10 to 15% variation suggests the fluid responsiveness. Passive leg raise more than 10%, and also the fluid challenge and echo similar criteria more than 10%. So think of 10 to 15, 10 to 15 for the PPV and SAV, and more than 10 for the non-ventilated patients. But again, so depends upon individual centers, objective evidence, expertise, training, equipment. All of these are the important parameters to consider. So part B of the fluid responsiveness tools, let's apply them in clinical practice. On the left side, if the patient is fluid responsive and still there are signs of ongoing hypoperfusion, which means the MAP is not achieved, the lactate is still high, urine output is still low, then you can continue with gentle fluid boluses and remeasurement, dynamic assessment again, which is the green box here, until you achieve the hemodynamic stability or the perfusion is pretty much restored clinically and no signs of fluid overload. On the other hand, if you have a patient who is not fluid responsive or has sort of responded and then plateaued and still needs further support, then that is an indication that you would have to consider the vasopressors. That means you have to involve ICU or high dependency unit, whichever the case may be, because the body and the cardiac output, the cardiac system is operating at the flat part of Frank-Starling curve. So increased venous return, increased end diastolic stretch will lead to higher contractility in cardiac output up to a certain limit. So when it's steep, it works, but when it becomes flat, no point of further fluid resuscitation. In fact, that will lead to volume overload and further decompensates the cardiac output and can lead to acute kidney injury. In that case, you need to increase the capacitance of peripheral vessels, so vasopressors are needed. So that's the key thing. The third category is the fluid overload patient. So let's say aggressive fluid resuscitation has been done and now they've achieved excessive volume overload, weight gain of more than 10% from baseline body. Although please remember that this is the used in research threshold, but the SSC 2026 guidelines do not mention more than 10% weight gain as compared to baseline as a marker for, as a threshold for fluid overload. However, it's a clinical judgment. And we discussed before, any signs of volume overload, hypoxia, increased oxygen requirement, desaturation, lung crackles, if it's basal crackles, mid zones, upper zones, the higher the level of auscultatory crackles on the chest auscultation, it means the higher the degree of volume overload. Tachypnea, tachycardia. Again, tachycardia is a non-specific marker here because of the shock itself. The patient will be tachycardic. Also, the SOFA score worsening, sequential organ failure assessment score worsening, and JVP raised. So, in all these situations, you have to consider removal of the fluid with either intravenous diuretics like furosemide, or considering continuous venous hemofiltration or renal replacement therapy or ultrafiltration to try and remove the fluid. If the chemistry is normal, you may just need UF ultrafiltration. If the chemistry is affected, you may need hemodialysis and ultrafiltration, which means acute kidney injury with hyperkalemia, metabolic acidosis, etc., etc. So again, our tachy indicates the severe sepsis, septic shock. Severe sepsis is a redundant term. We should not be using it. Septic shock. The Brady indicates the slow response of the fluid resuscitation. AU and AG indicate the balance. So AU gold is our gold standard for the institution policies. Please follow your own policies. And AG indicates the balance, homeostatic balance of patients' hemodynamic status, volume resuscitation, and individualizing patient care according to each patient's comorbidities rather than one size fits all. And phase 3, the post-resuscitation, the third R or the S in the ROSE framework, which is stabilization. Now, phase 3, which is a post-resuscitation strategy, the two main domains are liberal versus restrictive. So the previous 2021 guidelines, basically, there was insufficient clinical evidence to recommend a proper strategy. What the 2026 guidelines did, that after they recommended that after 30 ml per kg volume resuscitation with persistent hypotension, which is still there, you have two approaches of either liberal or restrictive strategy, and it has to be individualized to patient and the system factors in terms of the resources available, the intensive care high dependency unit facilities, and the expertise. Now, again, it's a conditional recommendation with low certainty evidence. What is a liberal strategy? Why is it acceptable? So, if the patient is fluid responsive and you keep giving boluses and clinically they are improving, then fluid resuscitation strategy should still continue, dynamic assessment, etc., etc., and it depends upon the patient's tolerance. Now, when is it useful? When there are persistent signs or factors of hypoperfusion, for example, large volume depletion, ongoing fluid losses, gastroenteritis, severe volume loss, GI losses, and the patient is continuously improving with fluid responsiveness and resuscitation. And the risk of fluid accumulation is also a bit low. The clinical trials are mentioned here. You can search it up. The main caution is going to be the fluid overload, which we have to be very, very careful about. So again, the trials did not recommend, both published in New England Journal of Medicine and the Intensive Care Medicine journals in 2018 and 2023. They did not notice any significant mortality difference between liberal versus restrictive fluid resuscitation strategies. On the other hand, restrictive strategy, when it should be considered, anybody who still needs resuscitation despite volume resuscitation fluids and the patient still remains hypotensive or shows signs of hypoperfusion, then, and also they're at risk of developing volume overload due to comorbidities, cardiac comorbidities, renal, pulmonary edema, or they're actually developing fluid overload, then there is no point, as we have discussed about the Frank-Starling law and the flat part of it being operated upon. In that situation, you have to use vasopressors to increase the peripheral vascular resistance and hence increase venous return, which should improve the cardiac output. So that's the key thing. Different trials, the classic trial, REFACED trial, they looked at the restrictive versus standard fluid resuscitation, and there was no difference in the 90-day mortality between the two groups. Again, please remember, restrictive does not mean under treatment or under fluid resuscitation. It means you have to be careful. So you need to maintain the perfusion with timely vasopressors rather than further fluid boluses. So the name should not be considered as like misguiding you that we are trying to restrict the fluid resuscitation. That's not the case. It's judicious use of fluid resuscitation with clinical dynamic assessment and then appropriate use of vasopressors at the correct time. That is the important part. And again, the message in the SSC 2026 guidelines was based on very robust data of pooled 4 RCTs, which are mentioned in the lower box, classic, CLOVERS, refresh, and refaced. More than 3,000 patients assessed who were persistently hypotensive after initial resuscitation. They looked at the restrictive versus the liberal strategy, and there was no difference in mortality with 95% confidence interval spanning both sides of 1, and the relative risk reduction was also 1. Again, it's moderate certainty. However, there's no single strategy which fits all sizes. You just need to individualize the patient according to the parameters and use your local expertise, local institution policies and guidelines. As a disclaimer, this video is only educational purposes, not a standalone guidance for treating each and every patient with septic shock. And the final and the last phase, phase 4, is the active fluid removal. So the fourth R in my mnemonic, and the E, evacuation, in the ROSE framework. So let's have a look at it. So the phase 4 active fluid removal, this is a brand new recommendation actually in this guideline, although it's not labeled as such in terms of the ROSE framework, but this is one thing which they have recommended as a policy, as a guideline. This was not addressed in 2021 guidelines because there was no evidence. However, in the new guideline, for any adult patient with septic shock, after the acute resuscitation phase, consider active fluid removal if there are signs of volume overload. And it's a conditional recommendation and with very low certainty as evidence. So this is the caveat. Why fluid removal matters? Because The excessive fluid accumulation in septic shock in itself has a high degree of leads to a high degree of mortality, and 28-day mortality in different studies shows that in septic shock patients with fluid overload is greater than people without fluid overload, and it's observational association, and this study is not a proof of causation, so that's why the certainty is a bit low in terms of quality. Number two, fluid accumulation will lead to increased tissue edema, just like it's causing edema in interstitial spaces in the lungs and the skin and the peripheries. The same phenomena occurs at the tissue level, which will further impair the already compromised perfusion and oxygenation of the tissues and cells. And that leads to prolonged mechanical ventilation, contributing to venous congestion, intra-abdominal hypertension, all sorts of complications, and further rise in lactate, and which can lead to lactic acidosis and worsen the outcomes. The ROSE concept, or the ROSE framework, was resuscitation, optimization, stabilization, and evacuation, the last E. And I labeled them as 4 R's, as you can see: resuscitation, reassessment, post-resuscitation, the third R, and the final one was removal. So whichever of the two you like, you can use it. So the phase 4 is the evacuation of the de-escalation phase, which is based on the Mulbrain study published in Annals of Intensive Care back in 2018. Now, the SSC 2026 guidelines kept the same rationale and same language, but they did not refer to the ROSE framework as a framework to be used. So this is one thing that I've already mentioned before in my previous discussion. Now, we've touched upon the reasons for fluid removal, and like why does it matter. And now looking at the tools and methods, the two of the commonest ones are diuretics, like intravenous furosemide, usually the first step before you go for invasive measures. Anyone who has got a net fluid balance positive and has signs of volume overload, as we said before, hypoxia, vasocrackles, raised JVP, etc., etc. You have to monitor blood pressure, electrolytes, urine output, peripheral perfusion, rising serum creatinine levels, and also other salts like magnesium. And the guidelines in 2026, it's a conditional recommendation with very low certainty evidence. Second line is ultrafiltration or extracorporeal removal, including CVVH or CRRT, continuous renal replacement therapy, or continuous venous hemofiltration. This is considered when diuretics are either inadequate or you have to dialyze the patient to correct the chemistry. So that is the important part. Otherwise, the diuretics should be first line to consider. And the indications for fluid removal, I've already touched. No ongoing volume expansion and vasopressors are stable and decreasing requirements. So acute resuscitation is complete, but then you have signs of volume overload, including pulmonary congestion, worsening oxygenation parameters, peripheral edema, weight gain, and positive fluid balance plus basal lung auscultatory crackles. You have to assess cardiorespiratory function, renal function, perfusion, and clinical trajectory of the patient. Do not use serum creatinine alone as a marker, because AKI is not an indication for removal of fluid. It's a marker of acute kidney injury, which is one of the vital organs, and also it's one of the SOFA criteria. And also oliguria, because as I said before, urine output will gradually pick up once the perfusion is maintained for a reasonably good amount of time. The cumulative fluid balance of more than 10% of body weight gain is not a marker or not an evidence which SSC 2026 relies on. So it's just a research marker. So again, the evidence is low, but it should never be used alone as a sole indicator to be used for fluid removal, whether it's extracorporeal fluid removal through ultrafiltration or is it through diuretics. So let's look at MRCP example, albumin versus crystalloids versus albumin. So what is the evidence? So basically, the 2026 guideline, including statement 45, it suggests using crystalloids alone over crystalloids with supplemental albumin for fluid resuscitation. And it's a conditional recommendation with moderate certainty evidence. In 2021 statement, it was also conditional with moderate certainty, but what it suggested albumin in patients who had received large volumes of crystalloids. So the strengths did not change, but the certainty of evidence actually and the direction of the default flipped. That's why that in this table the default has changed, but in terms of the certainty, it's still the same. The evidence base basically in the 2026 guideline relies on 6 randomized controlled trials, which included almost 4,500 patients with septic or with sepsis or septic shock, and subgroup analysis. 69% from LBOs and SAFE trials supported by 5 systematic reviews, a transfusion medicine guideline, and 2 new RCTs. And the pooled study was notably the main finding of albumin having no effect on the 28-day mortality, and it had moderate certainty as an evidence. And there was also similarly no benefit on the 90-day mortality, new organ dysfunction, ventilator or vasopressor free days, etc., etc. Now, the albumin may improve hemodynamic variables like blood pressure and static filling pressures, but overall it did not lead to mortality benefits. So that's why, and also if you look at the cost, in terms of the very high cost and the logistics, it doesn't prove to be a cost-effective intervention at all. And that's why this important nuance in the 2026 guideline, it does not prohibit albumin use, but it does not suggest against it. So that's the key thing. This is the supplemental albumin may be appropriate after a large volume of crystalloid in selected patients with cirrhosis only. So that's the key thing. But it should be avoided in patients with traumatic brain injury. So please remember that this guideline for albumin use, we are talking about sepsis and septic shock. We're not talking about the therapeutic interventions in patients with spontaneous bacterial peritonitis and patients with cirrhosis, where albumin plus antibiotics reduce the renal impairment and mortality because of improvement of the oncotic pressure and the renal perfusion, etc. Similarly, hepatorenal syndrome, large volume paracentesis, all those therapeutic indications clearly remain and they are unaffected. It's only for the sepsis and septic shock. So this is the key fluid recommendation summary at a glance. Please remember it doesn't include all the recommendations because of the lack of time and space. There are some recommendations like use of starches and gelatin. The SSC 2026 has totally recommended against them, statement 46 and 47 of the guidelines. Then if you look at the second row, crystalloids as first-line resuscitation fluid in statement 43 is the only strong recommendation on this table. Okay, it is strongly recommended as compared to the suggest for the other categories as well. This is unchanged from 2021, both and strength and certainty. And it occupies the row where a CVP recommendation used to sit in earlier drafts of this particular deck. Okay, so that's important. So crystalloids first is the only thing that here the parallel will not hedge on, and everything else on this table is conditional. So that's the one thing. Please remember that. Also, if you look at the other recommendations, the only recommendation which is generally new in all this is active fluid removal, the last one. And septic shock, consider active fluid removal after the acute resuscitation phase. This is a generally new one, which is statement 89 of the SSC 2026. Now, for MRCP candidates, the 3 most likely exam targets are number 1, statement 44, which is the balanced crystalloid use, which is certainty is upgraded from low to moderate, and the recommendation itself did not change. So that's the important part. The evidence behind it has actually strengthened. The only exception is sepsis with traumatic brain injury, then you can use normal saline. Also, the albumin, statement 45, the default direction has changed. So crystalloids alone are now suggested over crystalloids and albumin. So this is the main recommendation. This is not a suggest against albumin, but this is like a crystalloids alone, much better than using combination. Albumin is used or retained after large crystalloid volume, especially in patients with cirrhosis, and to be avoided in traumatic brain injury patients. Both 2021 and 2026 guidelines and statements are conditional with moderate certainty, only the direction has flipped. Similarly, active fluid removal, as I said earlier, statement 89 is a brand new conditional, very low certainty, but only after the acute resuscitation phase has completed. Now, you have to understand that there is no standalone CVP recommendation, central venous pressure monitoring, which sits inside the statement 49, and that is about the dynamic measures statements. The guideline recommends against using the static measures of volume resuscitation like central venous pressure monitoring and pulmonary capillary wedge pressure. Instead, we have all the other tools of the stroke volume variation and the passive leg raising and echocardiographic left ventricular outflow tract parameters. So those are more important right now. So this is a summary slide. So you can pause here, take your time, and just take a screenshot, or if you want to just go through them, that would be great. Summary for anybody for exam preparation or your own revision about what sort of things to avoid and which the ones which have been de-emphasized in this 2026 guidelines, what has been retained and what is new. The ones to avoid or which are no longer preferred, as I said earlier, are the starches and gelatins for resuscitation totally out. Static markers alone to guide further fluid resuscitation, CVP and pulmonary capillary wedge pressure, we discussed no. Dynamic assessment is much better. And the use of normal saline as a default crystalloid because of the risk of hyperchloraemic metabolic acidosis. So those three are to be avoided. In terms of retained and refined, unchanged, but still applies. For example, 30 ml per kilogram rule of fluid resuscitation of crystalloids within 3 hours. That's really important. It's retained. However, it's the first phase of the 4-step model we have discussed about the rows or the 4 Rs. The reassessment during and after resuscitation is something which has been further highlighted in this guideline, assessing hypoperfusion, clinical status, volume status, etc. before you give further fluid resuscitation. And vasopressors for refractory shock, no need of pushing with more fluids because of the Frank-Starling law and the flat part of the curve we've discussed before. Using the vasopressors in ideal HGU-ICU setting is really crucial in this situation. And finally, the last part is a new and upgraded version. Some of the evidence which has been upgraded in terms of balanced crystalloid use, the evidence certainty has been upgraded. Similarly, the post-resuscitation strategy, it was insufficient evidence back in 2021, and now the evidence has been upgraded, and although the certainty is still low. And the only new recommended guideline or new recommended strategy is the active fluid removal, which is totally brand new. And this is to consider de-resuscitation after initial resuscitation phase to prevent fluid overload and to remove fluid overload accordingly.